Good evening, everyone. Thank you for joining me for Kaplan's third webinar in our series focused on racial inequality in medicine. I'm Letitia Smith, and I will be your host this evening as we discuss a very important topic, the impact of racial biases and misconceptions around Black pain on both individuals and communities. Joining me today is our amazing panel, which includes Nancy, Executive Director of the Kaplan Education Foundation, Zanaya, Addie, and Aishwarya. Hello, how are you this evening?
I'm doing very excellently this evening. Had a wonderful day and excited to talk about a problem that is very near and dear to my heart.
I want to thank each and every one of you for joining us. Before we get started, I think it's really important to table set this conversation. The term Black pain can seem really vague and abstract. And so before we start talking about the causes and what we're seeing, it's important that we sort of define where we're coming from to our audience. So when we think about the term Black pain, and we think about how that is applied in the medical and health community, what does that mean to you? Nancy, I want to start with you.
Sure. And so for me, Black pain, everything I experience, especially today, is from a historical perspective. And that is understanding that, especially for communities of color, specifically the Black community in the US, and how we can say globally, historically, Black pain has been ignored and has been kind of ignored, tolerated, and caused by a system that often requires or feels like it requires for it to ignore it. And so that's how I see it.
Zania, what does it mean for you?
I think Black pain in the physical sense means that typically providers don't listen to or don't believe that Black individuals are experiencing pain in the same way that every other individual experiences it. There was a study that came out of Harvard that specifically showed that there are, I think it was up to 20% of physicians that were a part of this study believed that Black people actually have different pain endings, like nerve endings, like the actual things in our body that allow us to feel and sense pain than people of other races, and therefore we don't experience pain in the same way, we don't feel pain, and therefore whenever we are discussing any problems or any diseases where pain is a symptom, that we're not believed, we don't receive adequate amounts of pain, and sometimes serious diagnoses can be missed because the provider is brushing it off as, oh, you don't feel pain, or oh, I don't believe you because you're just complaining. I think in a more broad sense, Black pain is all of the ways in which injustices have been perpetuated against our communities, and the ways in which we continue to suffer without proper recognition, without acknowledgement from broader society, and without attention to these issues.
Aishwarya, when you think of this topic, what comes to mind? Aishwarya, you're probably saying amazing things, but you're on mute.
I am. So just adding on to what Zania was saying, seems to be this higher burden of proof for people from the Black community to kind of defend their illness almost. So someone with stomach pain might have a harder time getting evaluated versus just being told to take Pepcid or something. And so I think that's very challenging in terms of getting someone the right diagnosis. And it's also very challenging psychologically because you are constantly doubting your doctors, and that has to be very challenging from, the patient point of view. And I think it also means that just in addition to the higher burden of proof, your providers are more likely to think that patients are medication seeking, or that they have not necessarily done adequate research. And so I feel like providers tend to assume that like white patients are more prepared almost. And it's just like people of color have to just kind of defend themselves a bit more, which when you're already having some kind of medical illness, it's just makes the experience worse.
And last but definitely not least, Addie, what does this term bring up for you?
Yeah, just adding to that, it means to me that white or maybe just non-Black physicians don't prioritize pain as much when it comes from a Black patient, to the point where we have to give this term Black pain, almost to say we also experience pain, we are also human. To the like, and we'll talk about this later, but there are many reasons that can be. Maybe it's because our society like normalizes, or even sometimes you could even say romanticizes Black pain. Maybe it's through like media representations of Blackness. But to me, it means that basically physicians in the US at least don't treat Black pain like they do of other patients, to where physicians treating white pain got to the point where they were actually overprescribing medications to alleviate white pain, and this manifested in the form of the opioid pandemic. And so that was a result of caring too much, providing too much alleviation, as opposed to the opposite, which is what we're seeing is the common thread that's given to Black patients. And when the opioid epidemic happened, it was pretty recently, but there was this huge almost effort of the medical community to sort of eradicate it, to the point where some health profession schools were making that book about the opioid epidemic, which I can't remember the name of right now. I think it's Dreamland. From 2015 it came out, and that became required reading at some health profession schools. But it's interesting because health profession students are so incredibly busy already that usually the pushback about reading about Black pain, about reading about historical ways that Black pain has either been ignored or even caused in the medical field for centuries, usually like the excuses that we're already so busy, it turns into an elective, or it turns into maybe a short thread. And in my opinion, learning about mistreatment and inequalities in the healthcare system that adversely impact patients of color is not an option for medical providers. You have to be able to treat absolutely everyone, because otherwise, to me, the mistreatment will just, continue.
There were a lot of interesting threads there that we're going to touch on. The one that really stood out to me that I want to tackle first is this framing of the sort of notion of Black pain, the way that it's embedded in society. That's actually like Black myths, right? So something that came up a lot was this term of what does it take to believe a Black patient when they say that they're in pain or that they need something? What does it take to believe Black patients when they're telling you that something is off in their body? And I think a lot about what are the myths that we buy into around Black strength and Black pain tolerance and genetic differences between Black patients and other patients. And so I want to touch on that a little bit. Dania, I want to start with you. What are some of the myths that you feel persist around Black patients?
I think there are myths around Black patients with regard to physiology. There are also myths around Black patients with regard to how they act and how they interact with their providers as patients. And then there are myths in terms of how they perceive and how they utilize medical advice. So on the side of the actual physiology, it's perceived that we have different pain endings. It's perceived that we physiologically experience pain differently. It's perceived that perhaps different areas of our brain are activated when we are experiencing pain. When it comes to the patient-provider interaction, Black patients can be dismissed as being combative or cumbersome, or not asking the right questions, asking too many questions, and not following the provider's advice. And additionally, as being patients who are notoriously difficult to treat, and that some providers work hard to not accept into their practice. And then on the side of how they interact or how they utilize medical advice, Black patients can be seen as, we like to use this word in medicine called non-compliant, which is essentially you've counseled your patient to do a particular, to change something, to take a medication, to change their lifestyle in some way, and then they do not comply with that, quote unquote. And really it's a matter of asking what are the barriers to them being able to make this lifestyle change, and what better ways can we support these patients so that they can make these lifestyle changes, and so they can be perceived as to some callous physicians is a waste of time, because whatever advice that they are given kind of goes in one ear and out the other. And I think really the dynamic needs to be switched, and the physician needs to take the time to explain to the patient what's going on, to bring them along the journey, to have them understand what the logic is. And once they understand, they are much more likely to do their best to follow whatever they're asked to do.
One of the things I want to touch on, and Nancy, I'm going to be bringing this question to you, is these myths come from somewhere. They have persisted for so long. I wish I could say this is the first time that anyone has had this discussion before, but it's not. So Nancy, I know that you have done a lot of thinking about sort of the cultural and historical reasons. What are some of the things that stand out to you?
You know, one of the things that I have always found in the community, and as you know, I coach my own students and their families on how to access resources, both medical, legal, educational. Think about all of the institutions that often have left out marginalized communities. That's why they're marginalized. And I have found that the myth is often believed by the person that is being perpetrated against, right? Like there is this sense of lack of trust, the same lack of trust that exists from doctors to patients, that patients themselves lack the trust, or that the practice doesn't have what it takes to really bring out, to set about a comfortable environment where people are talked to in the same way that you would talk to someone that has been accessing healthcare all of their lives. And so I think that there has to be an education around how is it that you are going to treat a patient that has a lack of trust, that has not been able to access systematically the healthcare system, and therefore may not be able to be compliant with something that is being prescribed, or misuse the treatment, not because there's something intrinsically wrong with them, but simply because they have not been having access to that. So I think that it's just, you know, it's kind of this never ending cycle of, you know, a community that usually doesn't have access to the best care not being available to them, and then perpetuating that same myth that their doctors are not to be trusted, that they're trying to make money off of them. My own mother often believes, and this, I know it's, you know, oh my gosh, they're just trying to make money off of me, or they're trying to get me hooked on a medicine. And I think that, you know, this is where communication between patient, medical professionals, from the receptionist that welcomes that patient all the way through, that shows a level of respect, and to everybody's point here, to that ability to communicate clearly and to build trust.
So one of the things that we've seen a trend of over the recent few years to sort of focus on building that community and building that trust is a focus on increasing doctors of color, which is incredibly important. I want to say that. I want to say it clearly. We want more doctors of color. It doesn't fully resolve all of the challenges. When we focus on just increasing the number of doctors of color available to patients of color, we miss gaps. One of those gaps being the access to information that medical students see. Aishwarya, I want to start with you. Like, you are a woman of color who cares about these issues. What are the gaps that you see in the information available to you as you're learning?
I think there are a lot of times where we learn about a disease overall, and we learn indications that are visual indications, so changes in skin color, or like bruising, and there are things that are just harder to see on darker skin. Like, my skin doesn't show bruises. Sometimes I figure out I have them because I feel pain when I run into something. And so there's a really big gap there in terms of a lot of misdiagnoses, just because we don't know that these are things we should be looking for on darker skin. And there are a lot of times where I'll raise that question and say, okay, well, what would we look for on a really tan patient, or like a Black patient, or a Indian patient? And they'd be like, oh yeah, you know, it's kind of the same thing. Like, if it's jaundice, like, oh, well, their eyes will be yellow. And you're like, okay, but that's a really big difference if you're telling us to look for incredibly yellowed skin, and that's a hallmark of this disorder, and you're not even mentioning to look at their eyes unless I bring this up. Like, I think there's a really big gap in how we're taught, and it's more like an afterthought if someone asks the question, or mentioning things about race are usually just like an afterthought before you move on to the next topic versus a discussion. And one of the things when I was learning about it, there's a specific calculation you use for kidneys, that there's one version for everyone who's not Black and a different version for people who are Black. And there's no really good basis for it. The rationale is that Black kidneys are different and filtered differently, which really, like, again, there's no basis for it. It's as a hypothesis, then you'd ask yourself, okay, well, why wouldn't that be true of like Asian kidneys versus white kidneys versus Antarctic kidneys or whatever? But no one's really looked into it. And it's just this idea that's persisted. And I think there are a lot of standards that were established just because someone 50 years ago was like, yeah, I do it this way, so you should do it this way. And that's been handed down, but no one's really questioned it or looked back on it. And now, luckily, they are questioning the kidney calculation, and hopefully that opens more doors into other assumptions that we make that aren't actually valid.
Ashwarya and I had a great conversation last week. And so your comment on jaundice impacts me personally, since I personally have someone who was jaundiced, a woman of color, my mother, and it was almost missed by white doctors until a doctor of color looked at her and was able to identify it, which brings us to a really important point. Addie started off with this, saying, if a doctor can't care for all of their patients, that means that doctor is not actually fulfilling their commitment to care for a community. And so, Addie, I wanted to ask you, how do we shift the conversation to focus on how we improve the care that patients of color receive from their white doctors?
Oh my gosh, don't get me started. So going off of what Ashwarya already said, I think she mentioned like the EGFR initiative for kidney failure, and I think there's a group out of UCSF doing like a racial justice initiative right now that's has gotten a pretty wide reach already, but we really need to be more inclusive when we talk about how diseases present, I think, in medical education. As a first year, I've already even experienced things like people saying, you do like an oral exam and you look for pink gums. I don't have pink gums. My gums are darker. So just like little things like that. And for that, I'll mention another resource, a book called Mind the Gap. It was created by a medical student in the UK or somewhere else, but it's a book of how diseases present on darker skin or just on non-white patients. So what you mentioned about, we do need more Black doctors. That is a definite yes, because we have disproportionately low numbers of Black medical providers for various reasons. But something that stuck out to me was when I saw an article that said, and I quote the article title, I will probably never forget this, "The lack of Black doctors is killing Black babies." And when you read the article, basically the whole point was there was a study, linked this study where it was found that white doctors were 3 times more likely to kill Black babies than Black doctors were. And so my first thought is, how in the world, with our I think it's 5% of the U.S. physician population is Black, with our 5% of Black physicians, are we supposed to be present for every single delivery? How are the Black cardiologists and internists? Like, why was that the title? The lack of Black doctors is killing Black babies. Because from the way I see it, the white providers that were 3 times more likely to kill Black babies for various reasons, for who knows what reason, for internal biases, for the things that Zonia mentioned. Maybe we don't listen to the Black mothers. Maybe we treat Black babies more harshly. And I say maybe, but I really don't need to put maybe in there. And so that really gets me thinking, we need more Black doctors because there are structural barriers that are put in front of students of color that are not put in front of white students, whether they're social or whether they're concrete barriers. But we don't need more Black doctors for the health of the Black community. We need to teach all doctors to treat all patients. If Black doctors can treat both Black patients, white patients, Asian patients, Middle Eastern patients, everything, that's expected. We know that. But if non-Black doctors or non-doctors that just aren't patients of color, people of color, can't treat patients of color, then we have a huge issue, and we need to start identifying that issue. That is the stem of the problem. And I don't think that by saying we need more Black doctors, we are getting to the stem of why the Black community faces all of these issues in getting their healthcare needs assessed properly.
I think one of the things that you've pivoted us to is the real consequences of the difference in care. It's one thing for us to talk and say Black pain matters and it feels different and talk about it at a high level. It is different, though, to acknowledge that there are communities that are impacted. So when we say that we are treating the opioid epidemic like a healthcare epidemic, yet we have many people of color in jail for addiction, that is an impact on a community. Zania and Aishwarya, I saw you both sort of make a raise to jump in. So Zania, we're going to start with you, and then Aishwarya, you can jump in.
Yeah, to follow up on Addie's point, I think the most salient point of that article is that white providers are killing Black babies at 3 times the rate of white babies. And to not lead with that as the headline and to not focus on that failure as our healthcare system is the fundamental issue of that sort of analysis. I want to speak directly to white providers in America and ask them to think back to when they were writing their very first AMCAS essay, when they wanted to become doctors, like what motivated them? And for most of us, it was fundamentally people. And to be practicing medicine and to be actively letting go of some patient populations, not paying more attention to some patients than other patients, you are fundamentally undermining the entire reason that you put several $100,000 and several years of your life into pursuing this profession. And so I look to you to hold yourselves accountable, to hold your peers accountable, and to ask your institutions to provide you with the data that you need to objectively assess whether or not the outcomes that you are seeing in your patients who are poor, your patients who are Black, your patients who are non-white, and your white patients, and challenge yourself to go beyond thinking, oh, they're already coming in with worse health conditions to, well, how can we get them all to as close to the same level of health as possible? Pivoting back to the other conversation that we were having, I think that it is incredibly salient and important for providers to really pay attention as they are teaching the next generation of physicians who are coming up. Studies have shown that like one of the most impactful ways that medical students actually learn racial biases and learn to treat their Black patients different from their white patients is when they watch their residents and they watch their attending physicians, probably in moments of frustration if we're trying to be kind to them, treat their Black patients differently, walk out of a room and make a disparaging comment about a patient of color, and then prescribe different regimens for them based off of that. It is completely appropriate and good to prescribe a regimen that is lower cost because your patient is lower socioeconomic status, but it's not appropriate to assume that your patient can't afford it, to not have those conversations with your patients, and to not even provide them with what their options of what could be possible for them based off of what their condition is presenting as.
Aishwarya, did you still want to chime in?
I actually don't remember the original question, but like one thing I'll say is way back when, historically speaking, they noticed that doctors were killing like women who delivered children that were delivered by doctors, their children, and the women were dying at a higher rate than women who were delivering children that were delivered by nurses. And that led to major systemic changes, which ended up being like hand washing and better sterile techniques. So like history has shown us that when we make these observations, there's something that needs to change, and that change leads to better outcomes. So just kind of adding on to what Addie said, like I think everyone, well, no, that's not even true. I wish everyone acknowledged that there was an issue. So I think that's step one. And so like, that's one of the things I really hate speaking out. It makes me very uncomfortable, but I have just like felt the need to do it because no one else is really doing it in my class as much. I will take that back. People do speak out at my class, but like in smaller groups or with residents or in different situations, there are voices that I think have more like power that just don't use it. And so I feel the need to, and I really, really wish that people would use the power that they have, because a lot of people do come to me after and say, I'm glad you said that. It's like, but you could have done it too. And like we could have done it together, and that would have been so much more powerful and strong. And I think there's a good push in medicine where people are finding their kind of voice and their autonomy and acknowledging that things are wrong and need to be changed. But I think that needs to be so much bigger.
One important takeaway from this section is that we are not advocating for colorblind treatment, right? Like what's really clear to me as I hear each and every of our panelists speak is a belief that all doctors are able to assess their patient based off the information in front of them and the tools and resources accessible. And so really the question is, how do you identify the biases that are keeping you from fairly assessing and listening to your patient? And then how do you take action against those? Addie, I saw you coming off mic, so I want to pass it to you.
Yeah, I just noticed a connection between what Ashwari was saying and a comment that was left by a guest that says, what can we do to hold white physicians more accountable for disproportionate outcomes in communities of color, which connects back to what you said about one, how do we measure it, and then two, how do we attack it or approach it? And I think I can definitely empathize with Ashwaria's frustration sometimes, and there are people who care about this, but it's just not almost like not considered as big of an issue, or people tend to hold back these opinions about racism. In healthcare, we all say we know it's not okay, but it's not exactly always how we act. So I'm the same way. Like I'm not one to ever want to speak in front of a crowd. My heart's probably beating at like 150 beats per minute right now. It's just that not many people step up to do this, and it's so important that it gets you out of your comfort zone. So basically, to wrap that up, I don't have the answers to how to hold physicians accountable, but the least we can do is to be direct and to start with identifying the racism and holding people accountable. I think, again, Ashwarya already said this, but we need to hold people accountable. And as a society, I think we sometimes even discourage or punish pointing out racism. We make excuses. We say it's their age, it's where they grew up. We'll make any excuse under the sun. We'll gaslight, we'll tone police people of color, and we'll focus more energy on policing people who point out racism than we will policing racism, in the hopes of creating a more comfortable environment, making sure people are comfortable. And so this, I believe, leads us to dilute anti-racism initiatives. It leads us to dilute even our language, and words are so important when we point out racism. So I think that focuses the blame away from the perpetrators of racism, almost like how the article said, lack of Black doctors is killing Black babies. No. So we shift that blame away and to make everyone more comfortable, but it's at the expense of communities of color. And to me, I don't know how you can rehabilitate people that are perpetuating, just not violence necessarily in this context in the medical field, but it is a sort of violence. It's reducing people's qualities of life and people's health, and it's very important. But how can you truly hold them accountable for their actions if you don't identify them in the first place? I think that lends us to be able to avoid our internal biases as opposed to reckoning with them and really tackling them so that we don't affect these patients in the future.
So I want to pivot us slightly. Nancy, I will pass the next one to you. I think this will be right aligned with what you're thinking. I want to pivot us slightly to talking about how all of this is impacting a very real issue happening today. Individuals, communities of color, Native Americans, Latinas, Latinos, Black individuals are currently dying at a higher rate from COVID than any other community. That is for many reasons. And I want to be very thoughtful that though we say that Black individuals are dying more than white individuals from COVID, it is not Blackness that is killing them. Seeing what we are seeing unfold with the COVID epidemic, what is striking a chord with you as you consider the care and consideration around the needs and health and welfare of Black communities? Nancy, I know that you've been thinking a lot about the impact of COVID, so I wanted to pivot this one to you first.
Sure. So, even in the program that I work, I've had about 3 of my students lose, a parent, and one of the things that I have been extremely aware of, and as COVID has ravaged, I live in New York and it has ravaged my community, and it's gone across so many of the people of the neighborhoods where I live. What I have found is that whenever just a diagnosis, accessing just a diagnosis, accessing a doctor, accessing, understanding, getting information as to what it may feel like, where are the resources for you to be able to even just to self-diagnose and therefore then seek treatment. Those things are pretty much something that someone can consume if you have the time and the ability to really get to all of that information. The fact is that in COVID, many of our communities were the essential workers that we are talking about. And there was really no room, just like right now, whether past COVID, before COVID, there is this great sense that our communities are often in financial crisis, and even communities of higher income of color are finding that they just don't have the same access to healthcare. And healthcare starts with prevention, right? Diagnosis, and with the ability for you, if you are diagnosed with COVID, to not go to work. The fact is that the question is, if you are diagnosed with COVID, is your employer going to recognize that enough to say, well, not only are you putting at risk, but your life has value. So there's so many different dynamics here that have caused COVID, that have enabled COVID to spread in our communities in a way that has been much more destructive to the entire income, right, of a family. Think of many students and families where multiple generations are working to support that household. And so think about that there is really very little room for you to escape, for you to really quarantine. I love those pictures that they put on the television, and you have people, with multiple tables and all of this. The reality is that many communities can't afford that. They don't have that. That's not the life in urban centers, right? Even for wealthier folks. So I think all of those things are considered, and that has to be recognized by practitioners who must make diagnosis accessible to everyone, and then employers to enable those people to be able to take time off and to be able to recuperate and not have to go back and infect other people.
Nancy, one of the things that you've highlighted is, I think, a different lens of understanding where the disparities come from. And that's also like a lack of acknowledgement of privileged assumptions, right? So like there is bias, as in I'm assuming that my patient is not listening to me. There's also assuming privilege. Like I believe that social distancing is something everyone can do. I believe that getting to the hospital was easy for you. So you have mild symptoms and I can send you back home and you can get back to the hospital in time. And if you get more severe, to be treated. I believe that you have the time to take days off of work and still have an income and still have food. There's a lot of, I think, privilege in how we think about what are the things that people need in order to support themselves. I also think right now COVID presents an interesting dynamic in which Black communities are is a community being disproportionately impacted. It's also a community that is less likely to take the vaccine per recent polling. So Zanaya, I want to bring this to you. I know we've been talking a lot about how do white doctors create an environment in which Black patients feel heard and seen and supported. As we think about trying to rehabilitate COVID impacted communities, what are some of the things that we would like to see white providers take into account as they're working with people of color?
I think this starts with getting a sense for where the patient is at baseline, like what are their feelings towards vaccines, what is their usual outlook for it, and then digging into the reasons why they are feeling as if it is unsafe for them to take a vaccine. We need to take the creation of the vaccine out of the political realm within this country and move it back into the public health realm where it belongs. Yes, we can and should use political vehicles and processes to actually enable the delivery of the vaccine to market faster, but the actual testing of the vaccine, the timeline on which it happens needs to firmly remain in the hands of public health officials. Once that happens, we would then be able to approach patients with stories of how, this is like asking them, how has this affected people in your neighborhood? How has this affected your family? And help them make the link between taking this vaccine once it is proven to be safe and efficacious, and should definitely be delivered first to poor communities and communities that have been ravaged by COVID on the basis of need, not on the basis of market forces. And through those one-on-one patient-provider interactions, through utilizing community health workers to have the conversations, to talk to people about what their fears and concerns are about the vaccine, we will actually be able to enable people to feel comfortable taking it and see the benefit of being able to faster move society towards a world where everyone can go back to school in the way that we all used to.
We're getting a lot of good audience questions, so we're going to start to intersperse those into our discussion. We've been having a really rich conversation focused on how do we challenge the powers that be and change narratives that feel entrenched into our ways of doing things. With that in mind, I want to start with this question, which is from one of our audience members. How do we navigate this long-standing narrative in the healthcare place, especially when the people prescribing the pain meds or not prescribing are our superiors, our attendings? I know we noted that we're learning the habits by watching the doctors and attending. So what's the recommendation that you would have to navigating changing the narratives that we would like to change? And I will let anyone who feels passionate about this jump first.
I'll say selective ignorance has been working well for me, where if an attending does have different prescribing policies or something, I really just keep asking why. And I do police my tone to make sure that I'm not challenging. I'm genuinely just interested and curious. But really just asking why. And if they give me an answer that seems like it's rooted in racism, again, asking why and doing it in the nicest, sweetest possible tone I can, so they can't write me a bad evaluation. But I think that forcing people to explain themselves is a really powerful tool we have as learners, because as educators, they're required to give us answers, right? And if they're not, then you then have the prerogative to go and ask someone else. And it's not like you're tattling on them, but it's kind of a way of tattling to say, yeah, this person prescribed and they prescribed differently, and I really don't understand. And when I ask them, this is the response and I'm not really satisfied, can you explain it? And so you're bringing something that they might not be aware of to other people that are then on their level. And you kind of get a sense of who might be more willing to speak out about it and who won't when you're working with them. And so I think some people you can just have direct conversations with, but other times when you sense that that isn't going to work well, selective ignorance works really well.
There's an additional question that builds on this that I want to sort of nestle in. And then Addie, I actually want to pivot this one to you. One of our guests noted, how can we as POCs get providers and those in training who don't even believe that racism is real to understand racism in healthcare is a public health crisis, let alone get them to address their own implicit bias? As a POC in med school, I'm very concerned about the care my white cohort members will provide because they're committed to their ignorance. This is a theme coming up in a lot of questions. I actually want us to spend a little time digging here. It is one thing to shift the perception of someone who wants to do better and just needs the information and the data, but we're talking about people who feel like they're running against not just entrenched racism, but willing racism, the active decision to say, I don't want to engage in this discussion. Addie, is this something that you've experienced, or do you have thoughts on how you'd recommend a student navigate this?
I haven't had personal experience with this. I can give my 2 cents. I think that the question itself is so common and runs through the head of probably many minority medical students, including myself. I think that the way the question is posed is interesting as well, because it puts the burden and the weight of basically solving racism or making people see that racism exists when it's there on the people that have the least amount of power, which are the medical students. And on top of that, the minority medical students that are already not outnumbered, but, they're outnumbered. So it makes you, the minority voice with the least amount of power, responsible for changing the people that are up here, that are the doctors, the attendings. And so I think that first and foremost, it is the university and just the hospital's responsibility, the people that are at the top of the decision-making totem poles, to approach, like, this is not an acceptable opinion for a doctor to have, in my opinion. That's not an opinion, it's unacceptable. You cannot deny one's experiences. So that's one of my big things, is you cannot deny another person's experience. If somebody comes to you and says anything else, that's like, I was assaulted, something like that, you can't say, well, what actually happened? Does that fit my definition of assault? So these are experiences that patients of color are having, and you need to listen. You need to be empathetic. You need to understand what they have gone through. So when it comes to, sorry, I'm just rereading the question. Understand racism in healthcare is a public health crisis and make them address their own implicit biases. Yeah, I really don't know. There are studies. I think physicians are taught to be evidence-based, to practice evidence-based medicine, and there is evidence. So I think that if there's a physician that doesn't believe racism exists or racial inequalities exist in healthcare, really, like, they should be shown the evidence. But if they still don't believe it beyond that, that makes you question their ability to be an evidence-based physician.
Yeah, and I would also add, I know this is something that we've all discussed when we were connecting, and that's sort of come out in threads in this conversation. For something to be perpetuated, there has to be a system that rewards it. And I think there's value in identifying what are the rewards and then attaching your feedback to that reward. So if someone doesn't care about racism, that is awful and, like, obviously not okay. But there is a metric that they are judged against that they do care about. And, like, what can you do to get that, to Addie's point, to get someone who's data driven, who's metric driven, to understand how their actions to one group is impacting that metric. Nancy, I want to pivot this question to you because you support so many students. How are you guiding students going through these challenges?
So at the Kaplan Educational Foundation, our focus is really to bring leaders in all professions to their own communities, right? To be successful globally, but to always have a sense of identity. And I think it goes back to what Zonia and Addie brought up before, which is, to me, who is responsible for this? And the same thing about the question that was asked. I think that an undergraduate education that is not truly vibrant with issues of social justice, of race, of inequalities. Nobody makes it to medical school without going through an undergrad education. And what I have found is that many of the pre-med programs where our students have participated, there is a very, it's a lot of rigor, but not a lot of rigor when it comes to issues of, from sociology to psychology to all of these things. And so I think that I've always said to my students, especially those that are interested in, in medical practice, that your patients are going to be with you for a very short amount of time, right? They're going to be out there in the world living their lives with their bodies. And if you do not understand the lives that they will be living and what they are doing and value each and every one of them, and understand the dynamics, your ability to really model a practice that would yield healthy individuals consistently is going to be a problem. And to me, especially in a country or in systems where there's so much division based on income and access to education and other things, the question of how do we hold people accountable has to be, how do we hold educational institutions accountable? How do we hold them to make sure that any student that makes it to medical school has enough of a background that deals with social justice issues in terms of gender, in terms of race, in terms of anything that you can think will bring a bias, right? And so I think that that's important. Just like women, especially women of color, are underdiagnosed There's a perception, talk about myths, that we are more fertile, but in reality, fertility exists among us and at higher levels, where you may die at childbirth, more likely to die at childbirth, all of those things. I just don't think that there is an awareness or a discussion of how we came to be. And therefore, to your point, the reward there is that you can quickly ignore it because it's painful to talk about race. This topic that we're talking, it's not easy. It's not easy. And so to bring it up by the time that you get to be in medical school, it's a problem. And I don't think that it's there where the rewards will exist for you to change your mind or try to address it. There has to be a foundation of these topics being explored.
I think a really big part of that has to come from like the top in terms of board exams, because I think a lot of what we study, or at the very least memorize in the first few years of medical school, is kind of what we expect to be tested on. And so for the people that aren't interested in addressing bias or turning a blind eye to it, the way to kind of force them to pay attention is by changing it at that level. And so like we've been talking a lot about how it's important for people of color to become doctors. But I think it has to happen at all these different levels, even like the test making level, because there are just so many things, again, that are tied to like symptoms that we expect in white patients, but just never really discuss in people of color. And so if you force people to learn what those symptoms or signs are because they're going to get tested on it, then they might still be biased, they might still not have an interest, but at the very least they have the education. And doctors don't like to be wrong, so if they can diagnose someone correctly, they're going to want to. So I think like getting on the boards or being one of the question writers and encouraging those types of questions to be added would be a really important part of that as well.
Addie, did you have anything you wanted to add before we move to our next question?
No, I just want to say that's a great point about, putting the information where it seems to matter most to medical students.
I want to pivot us to a different topic that has come up a few times in our audience questions, and that's like the metrics that we're using to hold ourselves and doctors accountable. So one audience member asked, pain is subjective, and their question really stems on what are the recommendations that you have to fairly assess Black pain in a way that is inclusive and thoughtful, knowing that there is a subjective nature to both the patient side of things and the doctor side of things.
Yeah, so I'm in my the class where I learn how to take the history of a patient right now, and they teach us one standard way to assess pain in a patient. You ask them on a scale of 1 to 10, 1 being you bumped into the door lightly or like a very light, easy pain, and 10 being the worst pain that you've ever experienced in your entire life. How would you rate your pain on that scale? And then what's important is you take whatever number that the patient gives you seriously. You need to take into account what other conditions does this patient potentially have. So a patient with sickle cell anemia, their 10 is going to be somebody else's 100 because they experience pain that is far worse than even childbirth. Versus a small child, you might have to do a little bit more of like pressing to really see what like their physical reaction might be to ensure that they're actively assessing the pain. But take whatever number and whatever you're seeing the patient act as very seriously, and don't walk in with the assumption that the patient is lying to you.
We have a second question that says, patient-provider conversations are behind a closed door, so peer evaluation of care is difficult. What would you say is the best way to poll patients for quality of care? Not all patients like to fill out the Press-Gagne surveys. I probably did not say that correctly. But this is a question of, we know this disparity exists. We know that patients are getting less care, but there's also not a lot of insight into that. What can we do to change that narrative and to have a better understanding of how patients are perceiving the care they're getting?
I'll just say that I always Google my doctors, and I don't know if it's a Yelp thing, but like there's some place that sometimes I can find reviews. And I feel like that's really hopeful. And on one hand, the idea of like reviewing doctors is weird because like you might have the best doctor ever, but they might just be really gruff and like I don't know how that would come across. But I do think that there have been times where I've seen reviews that are like, this person really seemed to ignore the fact that like I'd gone through this, or they weren't listening to me, or I kept telling them something and they kept asking me questions that weren't relevant. And so I feel like having some kind of place to go to look at people's reviews versus just like an internalized hospital survey is helpful, especially for women and also people of color.
Nancy, I'll also ask you this as a patient. Oh, sorry, Addie. I just saw you come off. Do you have something to add?
Oh, yeah, just a thought about this. Just this question just makes me wonder, is there a way to communicate with patients to set a standard of care? You know, I think patients come in with different ideas of what to expect from their doctors going into the office. Patients of color might have lower like expectations because of past experiences. They might think that they go to the doctor and then, you know, their doctor writes them off, but then they think that's normal. Whereas a white patient who's not used to that might go in, get written off and say, hey, this isn't okay, because they're not used to that. So I wonder if there's a way to standardize for like with the patient, say, hey, this is the care, the standard of care that we want to give all patients, and so all patients can sort of start with that same standard. Is what I was thinking about that.
Yeah, I think that's great to sort of set expectations. And that naturally leads me to the question I had for Nancy, which is, as a patient, what would you like to see as a method that would be accessible and authentic and trustworthy to you to provide that kind of feedback?
You know, I have always seen patient rates. I'm a person that believes that you just need information in order to make the best choices. And I think both, you know, what are the doctors that are available to you? I think understanding the different practices. And let's be clear, you know, for many people, even of greater privilege, that information is not readily available or is something that you know. So I think that when we're talking about public health issues and addressing the lack of, you know, healthcare and the health of communities of color, as well as any marginalized community, you have to be intentional about, you know, how do you make the best patient, right? How do you support a patient to become the best patient and the best advocate of their own health? And that comes through information. It also comes through information that is spoken in a way that is familiar and in multiple languages, and that really respects, that doesn't downgrade, doesn't say that, you know, a person is not educated because of X, Y, and Z, or because of the way they pronounce something. That there has to be an acceptance that this country is wide and that it's diversity, it's wide, and that we have to provide information that really speaks to that person, and therefore that person can ask the right questions, communicate well with that physician, and therefore better assess that physician and say, that really was an appropriate question. No, you can't, you know, I need this, I need my records, I need this. So it's just like doctors need to be better educated, all patients need to also have the information to make the best decisions for their own health and their families.
So we are coming to the end of our hour. And that means we have two final questions that I want to wrap with. I would like every person on this panel to answer. We've talked a lot about the influence and impact and changes that we can make. I think one of the comments, Nancy, that you made earlier, and like Addie, you made, and everyone on this panel sort of hinted at, was that this is a hard conversation. It is an emotional labor for all of us women to be discussing this together tonight. It is an emotional labor for students of color to navigate through med school. And it can be hard. One of our questions is, how do you move forward when things are not changing or improving? And so I want to sort of address this question because I think that it's really important for us to also acknowledge this feeling of, what do we do when we feel like there are lots of factors against the changes we want to see? Addie, I'll start with you, and then we'll just go around the horn.
I think for me, what I would like to see happen soon is a change of frame or a change in focus, because personally, I'm tired about hearing about how minorities have worse health outcomes because of race without digging deeper and identifying and teaching that this is actually due to racism. How more Black doctors are needed to save the entire Black population because apparently no one else is able to empathize with Black patients, or how minorities, like communities of color, need to perform like band-aid fixes for their health, like community gardens and things like that, that we know are just band-aids and aren't going to fix the monstrous beast that is medical racism. And so I would really like to see our conversations turn from hyper focusing on communities of color, um, and identifying just like the negative effects and focusing on those, because I think that only completes half the job, because all we're doing is pointing, this invasive magnifying glass on the experiences of people of color, and it's almost like we're creating a stage for oppressed populations that none of them asked to be the lead actors for. We need to take a step back and look at what is the true cause of this beast of medical racism. So I would like to see that frame shift from communities of color, what's wrong with communities of color, to what's wrong with how we're treating communities of color.
Ashwarya?
I'm so sorry, I keep muting myself. I think part of it is just recognizing that by existing, you're kind of still like doing something, and by speaking about it to people and just having these conversations, and even like this kind of meeting where we're brainstorming a little bit, and like people watching are also hearing our ideas, potentially coming up with their own, and maybe feeling more confident in having their own voice, because it's hard when you think you're in a vacuum and speaking out by yourself, but it's a little bit more comforting to like meet Addie and Zania and hear about what they're doing, and then to meet Nancy and to hear what she's doing. And so I think it's kind of just like, it's frustrating, but you also know that you're going to keep doing it anyway. And eventually enough people are going to care and be involved in medicine, because this is going to be the majority opinion. And so we just keep going.
Nancy?
So for me, I live with a lot of pain of seeing the struggle of even people that are pursuing their own education in the best institutions across this nation and face racism. COVID has really brought out so much pain, right, in our communities. But I am also very hopeful, because I know how far we have come as a people. And so again, I go to history for hope, to acknowledge the pain that we experience. But I think we have to hold educational institutions more accountable. I think it's having conversations like this and engaging the entire community, to Addie's point, that this is not just for us to solve, that we really need everyone involved. And so acknowledging that in us taking care of ourselves. I think we have to honor and work with amazing women like these, and make sure that that we are all listening to each other and supporting each other. I'm hopeful because of that. I'm hopeful because, as you can see, they're doing it, and many more can do it. So just hopeful.
Zania?
So one of the quotes that gives me a lot of solace when I'm up late at night thinking about where I'd like the world to be is, the moral arc of the universe is long, but it bends towards justice. And I think we continue to bend it towards justice by doing the work that we do, by having these conversations, and by taking the time to imagine what a future, what things could look like in the future. We have come an extremely long way, and it's prudent to take moments of rest and reflection as you continue to push forward in this journey. And I think the second part is it's crucial and vital to utilize moments of crisis, moments of transition, to really think about what the timing is in order to make leaps and bounds in advance. And in the intermeeting time, when you don't have those moments of crisis, when you don't have those moments of leadership transition, to seek out the incremental change that you can in the areas that you are particularly interested in.
One of the things I love about that sort of came out is that Black pain matters, but Black resilience, the ability to find joy, the ability to support our community, support our family, the ability to believe in a better tomorrow, regardless of what we see today, like that is also incredibly important. I have one final lightning round question as we come to the end of our time. And that is, I want to do what Addie and Nancy and Aishwarya and Zanaya have challenged us to do, and I want to shift the frame of this conversation. So if there was one thing you would want a future white doctor to walk away and do after this conversation to challenge their implicit biases, to be a better care provider, what would that be? And we'll go in the same order so we keep it nice and easy. So Addie, we will start with you.
I think I'll touch back to what Aishwarya said about how there often aren't that many people speaking up, and people think that that means that they shouldn't speak up either. And I think it turns into almost like a bystander effect where they say, if someone else speaks up for this thing that's wrong, then I'll also speak up for it. But as future medical providers, you need to be that first person. You need to be the one that says, this is wrong. I am strong in my beliefs. And you know what? Take it or leave it. You are the leader. So, and even if you're not a future doctor, there are future PAs, NPs, nurses. You are the one in the medical field. You are the leader. You have an incredible amount of power and privilege to have that power over people's lives. So check yourselves, check your classmates, check your peers when you are a doctor, nurse practitioner, PA, and just don't be afraid to be that first voice.
So I would say don't put the responsibility on people of color to educate you about their biases. It's not necessarily my job to make you aware of your biases. What I would say is that the history of people of color is American history. So be very, and it's global history. There is, although there are special books that touch on this, if you really want to just look at things from a factual base, you will understand how we got here. And so I would say that make liberal arts a strong part of your education and of your readings, and make sure that you understand that it's up to you to determine, how important is social justice and how you're going to pursue it.
Aishwarya and then Zania.
So I think adding on to what Zania said, like even if you feel like you should have spoken up but you didn't, it's never too late to support that person. And there's a difference between after the fact telling them, oh, I'm happy you did that, which is reaffirming, but it's not as helpful as, if they speak up in that moment when you recognize that they made a good point, agreeing with them, especially if you're not a person of color, because that does tend to shift people's perspectives. And at the same time, like at each level of training, you can feel like you're very powerless because people above you are evaluating you, but you as a medical student have a lot of power with the administration. And, reporting things to the administration does lead to talks with whatever attending professor. And that might not mean that they don't get removed as a doctor, but it might mean that they have less interaction with students, which could decrease bias in that way. And similarly, as a resident, if you go to your program directors, you go to your chief resident, maybe you don't address it in the moment because that would negatively impact you, but you choose your battles. But always remember that you do have power at any stage of your training.
Yeah, I would say to the attending physician, the nurse practitioner leaders, to the PA leaders, to openly invite your team to speak up when they feel they are experiencing or they're seeing an issue of racial bias, whether that's perpetrated by you or by another member of the team. Do it in a way that feels comfortable to you. Do you want it done immediately in the room or perhaps afterwards, but openly invite that and empower your team to be a part of everyone advancing forward. I would also say that the medical students in the room, and also the nursing students, the PA students, you are powerful, and ultimately, hospitals are looking for leaders. They don't just want employees. And there are many places out there. They're going to look at a track record of standing up and speaking out and making a hospital a better place that is serving their patients in a more equitable way and ultimately getting better patient outcomes. That is going to be very much attractive on the job market. And so try not to let fears of retaliation keep you quiet.
Thank you all. We are out of time, which is shocking to me because the time has flown by. I want to thank each and every one of the panelists for just being so open, authentic, challenging our conceptions. And I want to thank every audience member for really engaging with us, asking us thoughtful questions, being open and raw about your own experiences. I feel very hopeful leaving this call that we are laying the groundwork for a better tomorrow. And I am just so grateful to have spent this time with you this evening. Thank you and have a great night.